A very good evening and a warm welcome to all the participants of this masterclass. I'm Dr. Madhvi from Christian Medical College, Vellore, coordinator for today's class. We also have Dr. R.K. Jena, Professor and Head Department of Hematology, SCB Medical College, Orissa, as the moderator. The topic for today's class, the third in the series of masterclass, is the interpretation of complete hemogram. It's an honor and a privilege to introduce the faculty for today's class, Dr. Sukesh Chandra Nair, Professor in the Department of Transfusion Medicine and Immunohematology. Sir is a name to reckon with in the fields of hemocytomorphometry, hemostasis and coagulation, automation, and quality assurance. This class will be for 45 minutes with a 15 minutes for question and answer at the end. Over to you, sir.
Thank you very much, Dr. Madhvi, for the introduction. And so thank you very much, ISHPT and Dr. Jena, for providing me this opportunity for this session. So, cell counters is something that's very common. Of course, now things have become more common than cell counters, like the PCR machines have become almost like a microscope that's available. But cell counters are used for counting cells. When we were doing the MBBS, we had the hemocytometer, the Nemo's counting chamber, which is called a hemocytometer. The cell count is also a hemocytometer. So basically, you should realize that it is counting and giving you objective values from the blood. But most of the people only look at the counts and report on the counts. Maybe look at the peripheral smear. Peripheral smear is an artifact because you make a smear. The spread of the cells is based on the weight of the cell, the attached affinity to glass. So it's an artifact, and you're trying to correct something which has been objectively derived from the cell counter with your peripheral smear. So I just wanted to go through some of these hemogram interpretation to convince you that please look at more than what the cell counter does. We know that hematology requires these basic parameters: hemoglobin, red cell count, which can be done manually because hemoglobin can have a manual method. Red cell count, white cell count, platelet count. Platelet count, of course, is quite erroneous because you're multiplying depth factor, dilution factor with so many errors that are likely to happen. And of course, you need additional information, red cell indices like MCV, RDW. We know that hemoglobin standard reference method is a colorimeter method. The hematocrit is a micropipette method, and the counts are counting chamber. Now you must realize that when you do these tests manually, there are tons of huge errors: sample identification, testing, manual testing, calculation errors, techniques resulting of wrong results, validity of results, release of results. A human technician can possibly give good results if he handles 25 samples to 50 samples a day. But if you're receiving 400, obviously one technician is not enough. You need to have more technicians who are also compounding the errors that I'm talking about. So in CMC Vellore, we get 3,200 samples per day. So obviously, I'm not going to depend on technician doing manual technique. I depend on the invention this great guy did, Wallace Coulter. He gave us the Coulter principle, which basically, on a simple fact that water conducts electricity. Now, if you divide the water container into two chambers, and in the middle of the chamber, you put a division with a small aperture in it, and if you pour water into the right-hand aperture, you can see that and open the tap, and when the fluid flows, all the non-conductive particles, when it passes through the aperture, it starts creating resistance because these are non-conductive particles. So each resistance is measured by ohm meter. And we realize that all the formed elements of blood, like red cell, white cells, and platelets, they are non-conductive particles. So this is the principle on the basis of aperture, that in the red cell chamber, you're counting the red cells and platelets. Of course, after they are diluted, in each red cell chamber, 30,000 red cells are counted before the dilution factor is added in, and platelets, around 10,000 platelets are counted before the dilution factor is added in. So every time a red cell passes through the chamber, it releases a pulse. Now, interestingly, the size of the pulse is directly proportional to the size of the cell. Not only is it counting the cell, but it's also sizing the cell. And based on that data that's collected, each cell will reflect as a single spike. Now, these spikes are divided into chambers, and with the help of the chambers and the events that happen, it creates a frequency histogram, a simple statistical frequency histogram. Now, this histogram finally reflects as the red cell histogram. Red cell histogram is probably the best invention in the practice of the field of hematology because of this histogram, you have a measured parameter called MCV, not calculated, and a measured parameter called RDW, which is the anisocytosis. Not only tells you about the average size of the red cell, but it also tells you how the red cells are widely distributed or not widely distributed. In fact, the most common hematological condition in the world, iron deficiency anemia, cannot be managed without these two parameters. In the same chamber, you have the platelets which are being counted. Any events that is less than 20. Now, I think many of the cell counts extended 25 to 35 milliliters are platelet. And what it does is the same frequency histogram it plots, but it has also got a smart thing. After the frequency histogram is plotted, it puts a fitted curve. You can see another curve going. This is basically to see whether I can accommodate a little bit of large platelets, which is part of physiological anisocytosis. You know, every person may have 1 or 2% of large platelets. So that's called physiological anisocytosis. Not necessary all the time, but it accommodates for those platelets. And once it fits the curve, the area under the curve is the platelet count. So you must realize that unlike red cell count, where each event is directly proportional to the red cell count, platelet count is actually a derived parameter from the platelet histogram. So you can realize that what is measured here is not the platelet count, is what is measured here is the platelet histogram. That's the measured parameter. Like red cell count is a measured parameter. MCV, RDW are derived parameters. They are not calculated, but they're derived from the histogram. Similarly, platelet count and MPV is derived from the histogram. The measured parameter is the platelet histogram. Now, of course, these are the histograms with the cell counters. Now, iron deficiency anemia, as I said, you know, we talk about anisocytic hypochromic anemia with anisocytosis. Now, you can see here, from the value, we can know that there is MCV is low and the RDW is high. So there is microcytosis and anisocytosis. But if you look at the microscope, sometimes size can be deceptive because it's fairly objective. It's not, it's fairly subjective. It's not objective data. But if you look at the color is so varied. So anisochromia may be a better marker of iron deficiency anemia rather than anisocytosis. So now you have another histogram here, red cell histogram, which reflects an MCV of more than 120. So diagnosis is very easy. Yes, any MCV more than 120 is megaloblastic anemia. But we also realize that there is something else in megaloblastic anemia which is more specific than red cell size, the hypersegment neutrophils. This can also tell you about dimorphic anemia because red cell histogram will show the 2 peaks. Then it will also reflect the anemia because of autoimmune hemolytic anemia because there are autoagglutinated red cells. You can see the histogram getting extended. So there's an artifactual raised in MCV. But if you look at the histogram, we know that it is not megaloblastic anemia, but some agglutinated red cell, which is causing that large histogram. Microangiopathic hemolytic anemia is also very classically identified because there is a merger of the red cell and the platelet histogram. You must realize that red cells are in millions, platelets are only in lakhs. So a little bit of small red cells get into the platelet count will get exaggerated. However, many giant platelets or large platelets will not affect the red cell count as much. So you don't ignore about, you don't have to worry about the red cell count, but you have to worry about the platelet count. So you can see the overlap between the red cell histogram and the platelet histogram. And red cell, if you get an MCHC of more than 36, which is a calculated parameter, but even if it's calculated, it will give you 2 important diagnoses. One is hereditary spherocytosis, and the other one is sickle cell anemia. In the WBC bath, what happens in the WBC bath? In the WBC bath, we don't want the millions of red cells and the lakhs of platelets to affect the white cell count. So everything is lysed, including the white cells. You can't have the white cells specifically resisting the lysis. But here, what is the non-conductive particles here? What was inside the cell? If it is the case of WBCs, all the nucleus of the white cell, nucleus of lymphocyte, nucleus of neutrophils, nucleus of monocyte, but not the cell as such. The platelets somehow resist lysis because they remain as platelets. So there's a small chance that a few giant platelets can affect the white cell count. If suppose there are some inclusions in the red cell like malaria, nucleus of the RBCs, they also get included in the white cell count. Now, since the red cells are lysed, the cell counter uses the opportunity to measure the hemoglobin that comes out of the red cell to find out what is the hemoglobin in this particular individual. So again, the same impedance principle, where resistance will cause the peak. The height of the peak will be directly proportional to the size of the particle. Now, if you look at the white cell histogram, the smallest particle is the lymphocyte nucleus, because cytoplasm is gone. Now you can see that most of the events are beginning with the lymphocyte. Now, if you look at the largest event, are the lobed nucleus of the neutrophil. So lobed nucleus of the neutrophil is large. So if you start from 400 femtoliters, 400 to 350, you'll have the 5 lobes. 350 to 300, you have the 4 lobes. 300 to 250, you may have the 3 lobes. Then from 250 to 200, you have the 2 lobes, followed by the 2-lobed eosinophil, and then the basophil, and then the monocyte. You must realize monocyte, though it's a large cell, once it's sliced, only the small nucleus is a particulate matter. So monocyte is large cell, but in the 3-part histogram, it's a small cell. It's closer to the lymphocyte. Now, if you see a WBC histogram like this, now you must realize that I can't see a lymphocyte, but lymphocytes are there. Now, if lymphocyte peak cannot be seen, that means the peak on the other side is so large, maybe the white cell count is 300,000, 3 lakhs. That's why the lymphocyte is dwarf. Now, what is the 3 lakhs? It's predominantly neutrophils, and you can see that it is left shifted. It is the slant is higher to the left shift. So you can see that there could be metamyelocytes, myelocytes. So if you have a high white cell count, which is bell-shaped curve, anywhere in the world, there is only one diagnosis: CML in chronic phase. You know, without seeing a peripheral smear, I can confidently call this as CML in chronic phase. However, if CML is in a different phase, for example, if it is in a blast crisis, you can see that the same histogram is there, but there is also a peak towards the lymphocyte and the blast area, which is around the 100 femtoliters area. That is a CML in blast crisis. And the CML, when it goes into accelerated phase, you can see the peak of the histogram shifting from the 200 area to 100 area. So that is CML in accelerated phase. And what you see now in the blue histogram is actually a mirror reflection of the CML in chronic phase. It is nothing but chronic myelomonocytic leukemia. And you can see that most of the monocytes are in this particular region. Now, coming back to megaloblastic things, we said, okay, MCV more than 120, megaloblastic anemia. But where are the hypersegmented neutrophils? We saw the histogram, the white cell histogram. Now look at the patient and compare to a normal control. The blue histogram is the patient's, and the normal person is the white histogram. And you can see that compared to the, did I lose the presentation? Okay, sorry. Compared to the normal, there are more neutrophils after the 300 femtoliters mark. They are nothing but neutrophils which have got more than 5 segments. They are the hypersegmented neutrophils. But more than that, look at the valley between the lymphocyte and the neutrophils. When you get a valley like that, it is always hypersegmented neutrophils. But the problem with megaloblastic anemia is sometimes you can have a dimorphic anemia. You can see that there is a dimorphic anemia here, but you can hardly see the two population, because the histogram, if you look at the RBC histogram, it's a slight division between the large cells and the small cells. But if you look at the white cell histogram, you can see the valley and you can see the hypersegmented neutrophil, which is outside the 300 femtoliters mark. Here, of course, you can see the dimorphic population, but the white cell histogram will also help you with the 300 femtoliters mark. Here, the MCV is normal, 87.5, which can happen in patients who have got severe iron deficiency along with megaloblastic anemia. The iron deficient component will be stronger, and you can see the valley there and the hypersegmented neutrophils, which can tell you that, yes, this guy has got both iron deficiency and hypersegmented neutrophil, even if there was no double peak in the red cell histogram. So white cell histogram is an amazing information that you should not ignore. So this is usually the hemogram printout, So most of the doctors are only interested in the values, and most of the the pathologists, clinical pathologists or the clinicians, they will also look at the numbers. They will not look at the histogram, even in the lab. So suppose I have got 3 individuals here, all 43-year-old male. I have got values on the first one. If you just scan through, everything looks normal. The hemoglobin, white cell count, MCV, RDW, platelet count, everything looks normal. Compared to the next person Next person looks like also having normal hemoglobin, but the MCV is low. The MCH, okay, borderline or low. MCHC is fine. RDW is normal. Platelet count is slightly low, but the MPV is larger, more than 11.5. So that means there are giant platelets. The third patient has got close to about, hemoglobin is low. And the reason is that there is a microcytic hypochromic red cell and the RDW is high. So we have microcytic hypochromia with anisocytosis. It is iron deficiency. Now platelet count is slightly high, normal MPV. So my question to you is, would you like to see the slide on the first case? Would you like to see the slide on the second case? Would you like to see the slide on the third case? Of course, I can't see you directly, so I can't see a raise of hands. But you must realize this is normal. So why should I see the smear? Now, when you place a cell counter in your lab, the cell counter will ask you what is your normal reference range. What is your normal MCV? So I'll say that my normal MCV is 80 to 100. So if your MCV where the cell counter is less than 80, the information called microcytic red cell comes to you. If the MCV is more than 100, macrocytic red cell comes to you. If the MCH is less than 27, hypochromic red cell comes to you. If the RDW is more than 15, anisocytosis comes. All this information are called definitive flags because that is defined by a reference range, which has been fed into the machine. So now, based on the definitive flag, which is compulsory for all cell counters, this is the information that has come on these patients. This one is basically, most likely will be a person from eastern part of India who's got HBE. That's why he's got low MCV and normal RDW. And he must be having macrothrombocytopenia, which is very common in eastern part of India. And these common, at least 30% of patients coming to Vellore are these types. Then the last patient is nothing but iron deficiency anemia. What extra information are we going to add by looking at the smear? Pencil cell, target cell. Anyway, the information from these definitive flags are very clear. And what happens is, many of the Indian doctors, when they send for investigation, they'll only ask for hemoglobin. But the cell counter does everything. Some people will ask for hematocrit. Surgeons usually ask for hematocrit. But cell counter does everything. But what I do is I allow this definitive flag information to go to the LIS, where you have the pediatrician, the physicians looking at the results. And when they see microcytic red cell, they will want to know what the MCV is. So they'll call me, what is the MCV, Sukesh? I'll say that if you ask the patient to pay for MCV, it will automatically come on the record of the patient. So I can, using this information, I can actually extra make some money for my hospital. So you must realize that I will not see slides in any of these patients because the information of the cell count is very definitive. And there are international guidelines on when to see a smear and when not to see a smear. And, make sure that whenever you are establishing a guideline for cell reviewing a slide, you should have reference ranges. India doesn't have reference ranges for cell count or hematology. So you have to go through various books like Dacey. You can go through Hoffman, Hofbrand. You can go through Williams. You can go through Winthrop and see what is the best fit for your population and adapt the reference range from them because they are well-established reference ranges. And then decide your rules. For example, initial rule that if the white cell count is less than 4,000, review the smear. If it's more than 20,000, review the smear. Hemoglobin is less than 7. So all these were the old rules. But the rule was that all suspect flags, you have to review the smear. But that also we need to look at it very carefully. So based on the slide review rule, we looked at the truth table. When we use the ISLH criteria, we found that we had a high degree of false positivity, 2.8%. That means my review rate will be very high. But false negatives were 1.1%. Now, if I look at my old lab rules, I have brought down the false negativity to 0.9%. Because what is false negativity? That means your cell counter has missed a blast while the smear has shown a blast. So that fear is always there. Then I modified the new rules. And the false negativity came down along with the false positivity. But 1.8% among 3,200 sample is a lot of work. So then I modified the new rules and I found that my false positivity has now come to less than 1%. But my false negative rules have gone up a little bit. That's because the cell counter did not report an immature granulocyte when we saw a metamyelocyte in the peripheral smear. I'm not worried about that. So based on the strength of these rules, I looked at the kappa value and I found that the current modified rule had a good strength. So I have adopted the current modified rule, which does not look at the white cell count at all to decide on the peripheral smear. Now, why? There is because I trust the cell counter. Now, why does cell counter does better morphology? Because samples are analyzed. I mean, and the analysis of cells are 80 to 100 times more than any morphology checking process. 30,000 red cells. How many red cells do we count? Red cell count and the peripheral smear. Nowhere close to 30,000. And at the end of it, it arranges a proper output, a good histogram, and also many values, and much more. So coming back to a patient who had fever, and we found that there were some events that were happening beyond less than the lymphocyte area. So obviously there are some events which are less than, there are events which are smaller than the lymphocyte nucleus. Something that must have come out of the red cell. So the possibility of these events that are happening less than 50 femtoliters or less than 35 femtoliters are NRBCs, malarial parasite, or giant platelets or large platelets. If the patient has fever, highly think of malaria. You will look at the smear, you confirm malaria. But look at the histogram. It will tell you that there is some inclusion of the red cell which is there in the blood sample. Now here, there is a 25-year-old male, two 25-year-old males referred for high white cell count. Now you can see the neutrophil histogram. This is almost normal. It's very high. The white cell count, the neutrophil count is on 30. The total count is on 45,000. Most of them are neutrophils. That's because the lymphocytes have dwarfed. But compared to the normal histogram, the neutrophils are normal. There is no left shift. But when you have a person with fever where the white cell count is 48,000, you can see that, okay, most of them neutrophils. You can see the lymphocyte has dwarfed a little bit. But if you look at the neutrophils, there is some hypersegmented neutrophil, but there's a left shift. That is an immature granulocyte. You can easily call up the clinician and say that this patient has got possible sepsis, just looking at the history. So if you look at a person who is referred for high neutrophil count, you can tell which is non-infection and which is infection. Now, when you have lymphocytosis where the WBC histogram almost looks like the red cell histogram, it is basically lymphocytosis. And if it's less than 100 femtoliters, it's only lymphocytes and not any other cell. But when you have a peak which is attached to the lymphocyte and is in the middle can be basophil, eosinophil, or monocyte. But when it's attached to the lymphocyte, it's monocytosis. But if it's not attached to the lymphocyte, it is eosinophilia. And when you have a histogram which is extending beyond 100 and then finishing off fast, that means there is a blast. It can be a lymphoblast, it can be a myeloblast, it can be an APML cell. Because you must realize the cells have lysed. It's only the nucleus that is being measured. This is a patient with AML M1. This is a patient with AML M4. You can see that there is a monocyte peak, there is a blast peak, and there is a left shifted peak. So that's an AML M4. And that's an AML M5 where mostly monocytic cells. Now here I have got lymphocytosis. You can see that there's hardly any neutrophils. Most of the cells are lymphocytes. What's your diagnosis? I haven't looked at the smear till now. I have not looked at the smear till now. Now, is there something wrong with this histogram? Let's compare it with a normal histogram. Okay. Now you can tell me the lymphocytes are looking smaller. So these lymphocytes are smaller lymphocyte, which is called lymphocyte microcytosis. When you get lymphocyte microcytosis, there are most likely diagnosed as CLL, otherwise follicular lymphoma grade 1. So this patient was actually a patient with CLL. When I look at this histogram, I can easily tell the diagnosis of CLL without looking at the smear. Now let's look at a clinical scenario. 17-year-old male, student of IIT Madras, has a preventive admission to ICU because the father is the head of ICU. Because the father thinks that this patient who had fever was positive for dengue, may develop dengue hemorrhagic fever, so put him in ICU. Unfortunately, his platelet count was coming down every day, 75,000. Then he said, shall we give platelets? I said, which patient with 75,000 you gave platelets? Then platelets were dropping. One day it was 4,000. He said, shall we give platelet? So I said, I see the WHO guideline says that the risk of intracranial bleed is only when the platelet count is 1,000. He believed me because I have not seen any cell counter give a platelet count of 1,000, because even if you run water through the cell counter, it will give you at least platelet count of 3,000. But to my bad luck, next day the platelet count was exactly 1,000. So he called me and said, now we should give platelets. Why do you want to harm somebody who is not bleeding, of course, platelet count is low, but they're large young platelets, they're hemostatically all right. Why do you want to harm him by giving platelets? So I said, can I look at the peripheral smear and I'll get back to you. So he said, okay, how long will it take? I said, what, 2 to 3 hours. Now, the question is, are cell count is reliable for platelet count when it is low? Most of you will say no. My answer is yes, it is very reliable, provided you use it appropriately. So when you do a platelet count, the platelet count is 76,000. As I said, the green is the impedance data, which is collected raw by the impedance signals from the cell counter. The black is the fitted histogram, to accommodate for any large platelets. Now, if you look at most of the distribution of the platelets, normal distribution, because most of the distribution is less than 10 femtoliters. There's hardly any events between 10 and 20 femtoliters. This patient doesn't not even have large platelets. He doesn't have the regular platelet anisocytosis. So if I look at this histogram, I know that the platelet count is 76,000, even if I use flow cytometry gold standard method. Or I look at the smear, it is not going to be more or less than 76,000. Here the platelet count is 21,000. You will say, please look at the smear. I will not look at the smear because I look at the histogram. Majority of the distribution of platelets is normal. Majority of the platelets are less than 10 femtoliters and the distribution is normal. Platelet count, even if I look at the smear, is not going to be more or less than 21,000. There are some events which can happen. Now, even if you look at this patient, 79,000, majority of the platelet distribution is still less than 10 femtoliters, but a lot of events have started happening between 10 and 20 femtoliters, means the physiological anisocytosis is slightly more. And maybe there are some platelets which are larger than 20 femtoliters because the green signal is still active. So the histogram which is fitted extends beyond 20 femtoliters to accommodate for those platelets because it's going along the slant of the curve and then gives you a platelet count based on area under the curve. Even if I look at the peripheral smear, you can see the peripheral smear. There are a few large platelets. It's not that it is everything is normal platelets. There are large platelets, but the histogram has accommodated them. And even if I do a manual platelet count, it is not going to improve the platelet count. So when there is no curve, for example, in this patient, there are a lot of large platelets. You can see the number of large platelets are very high in both the smears. Platelet count is 96,000. The events are actually increasing between 10 and 20 femtoliters. And after 20 femtoliters, the curve fit is not going to happen because the distribution is abnormal. Cell count is confused. It will not accommodate for this. When I see a histogram like this, I will look at the smear. And I know that the smear will give me a platelet count of, in this patient, the platelet count was 2 lakhs, not 96,000. So can we trust anything like this in the situation like low platelet count? Is there anything that could provide confidence like MPV, platelet indices? Okay, here also the events are mostly between 10 and 20 femtoliters. The platelet count, manual platelet count on this patient was actually 250,000. Now here there's no curve fit, but look at the distribution. Distribution is normal because the cell counter got confused because of the small platelet aggregates and large platelets. So it did not fit a curve, but the platelet distribution normal. When I look at the platelet histogram, platelet count of 51,000, even if I look at the smear or do a flow cytometric count, it is not going to be different at all. And when you look at a platelet histogram like this, platelet count of 99,000 is an exaggeration because now you must realize that small red cells are being counted as platelets, and red cells being in million will exaggerate the platelet count. This patient's platelet count was 35,000 and not 99,000. And if I look at the histogram, I know that the red cells are exaggerating the platelet count, and I should look at the smear. Coming back to the 17-year-old boy, I have been looking at the smear from the time it was 75,000. You can see the topmost picture is this boy. Now, this boy was a normal boy. He was probably having normal platelets, but when he started developing platelet, consumptive coagulopathy, not coagulopathy, platelet consumption because peripheral destruction, because of dengue, you can see that his platelets started becoming larger. So he started developing physiological anisocytosis slightly more because of peripheral destruction of platelet. Now, when it was 10,000, you can see the this particular, below the writing, you can see that he has been producing very large platelets or large young platelets, and also the platelets that are being produced are small. Here also you can see that there is this is when the platelet count was 4,000, and the platelets are becoming almost the size of the red cell, but still not larger than the red cell. These are called large young platelets. Now, when you have large young platelets, we know that these guys are producing platelets which are hemostatically very active, but there is peripheral destruction. Now you must realize that these platelets, the small platelets also being produced in peripheral destruction when the platelet count is low, are also young platelets. They have been just produced because every platelet is getting destroyed. So when you when you have large platelets, what's the issue with cell count? We know that many of the large platelets may not get counted because of impedance, especially when it's ITP dengue. So you may probably not trust it. Giant platelets are different because giant platelets has definition. Giant platelets are those platelets which are larger than red cell, like you can see the patient with Bernard-Soulier here, with large platelets, and they generally will be missed completely in the platelet count by the 3-part cell count. So is there something that can help? For example, here you can see some normal histograms on top from 3 different cell counters. Now below that, I have got 3 histograms which shows that this patient is slowly starting to produce large platelets or large young platelets. And the lower 2 histograms are patients with Bernard-Soulier syndrome, which have got giant platelets. Now let's see whether MPV helps. Yes, in some cases, MPV help, provided the distribution of platelets are normal, like what we see with mild increase in MPV in the first patient, slightly more because the platelet distribution is still normal, but there are more large young platelets. And again, the distribution is normal. But compared to the 2 patients below, which have got giant platelets, MPV gets confused. It gives abnormal value. In fact, there are some cell counters which get so confused, they don't give MPV at all because the platelet distribution is absolutely abnormal. What is the alternative? Can we look at optical platelet count? So nowadays people are promoting optical platelet count, but you must realize optical platelet count can be based on 2 principles. One is based on light scatter, which is done by ADVIA, which is from Siemens, and Alinity by Abbott. And the others uses fluorescence, which are done predominantly by platelet O from Mindray and platelet F from Sysmex. However, both of them require additional testing. You have to do additional tests for platelet count, not in Alinity and ADVIA, but in the others we need to do the optical, the fluorescent platelet count. So here we have got a patient with Bernard-Soulier. You can see that one of the platelets is as large as a white cell. The impedance platelet count was 7,000, but the optical platelet count, because the patient had large giant platelets, was 88,000. So, okay, we say that, okay, fine, it's good that optical platelet count picks up giant platelets. But we also realize that when the platelet distribution is normal, the impedance platelet count is higher than the fluorescent platelet count. So this is based on fluorescence and flow cytometry. You can realize that when fluorescence is there, there's something called background noise, and they eliminate a lot of platelets based on background noise. So small platelets will be missed by fluorescent platelet count. May not be missed by optical platelet count, but fluorescent platelet count will miss the small platelets. Now, when you have a scenario here where there is platelet anisocytosis, where the histogram shows that most of the events are between 10 and 20 femtometers and still continuing, that means there are small platelets and giant platelets. We found that impedance and fluorescence agreed, because impedance missed the large platelets and fluorescence missed the small platelets. But actually, if you look at the peripheral smear on the right-hand side, there are 6 platelets easily identified on the sphere. Therefore, the platelet count is 90,000 per cubic millimeter. So in CMC, where the red cells overlap, 1 platelet is equivalent to 15,000 platelet count. So the philosophy in CMC is that when there is thrombocytopenia, look at the histogram, because histogram is the measured parameter and not derived parameter. Platelet count is derived parameter. If the histogram is normal, report whatever platelet count without looking at the sphere. If the histogram shows that there are large platelets, do a fluorescent platelet count and report the fluorescent platelet count. If there is platelet anisocytosis, look at the smear and report the smear count. Yes, so now you realize that you can trust if you look at the histogram. Now, for example, here we have got a platelet anisocytosis by histogram from a cell counter. Impedance is 23,000, optical is 67,000, and fluorescent platelet count is IPF. This thing is 70,000. Then we realize there's something called IPF. IPF is some 57.8%. So when we looked at the IPF, we realized that the IPF is fluorescent versus size. So if the cell counter, if the platelets are large, even if they are 10 days old, they'll be called immature. But if the platelet is small, like for example, here we have a platelet which is small, it will not be counted as immature platelet count because it's small in size, though it was produced 1 day late. So we realized that IPF is not a terminology that we should use, because when we did hematology, we never called platelets mature platelets. So Why does the term immature platelet come? And when we talk about dengue, these platelets are functionally more active. And if you call something immature, will you call them inactive or non-functional? These platelets are more functional. So it is a misnomer. It's a very bad thing. So we should not call anything as immature platelets. We realize that immature platelet fraction is actually identifying large platelets. They are not identifying in platelets which have been produced recently. They're only identifying large platelets. So you can see here, we have a lot of patients who come from the eastern part of India who have large platelets, and you can see that most of their IPF is more than 60%. You can see their pictures, They're not young platelets. They are all platelets which are probably 10 days old. And sometimes they are so large that they influence the white cell count. They increase the white cell count, give artificially increased white cell count. So please look at these histograms before you report thrombocytopenia. So IPF is the best misnomer in the field of hematology. If you want to call something immature because it does not function, stop bleeding, they are proplatelets, as you can see here. When Medications sometimes produce proplatelets, which goes into various organs, especially lungs, and they secrete the regular platelets from lungs. So for example, if you yawn, if you cough, you start producing platelets from the proplatelets. So you must realize that large platelets are always seen on the platelet histogram. We actually did a study where we actually took all the platelet histogram, and anything that was more than 21 femtoliters was called as a large platelet fraction. And then we put this graticule, and then we figured the curve on this graticule. And then any event that happened beyond 21 femtoliters, the area under the curve, we counted the squares. We call that as large platelet fraction. So when we looked at the percentage of large platelets and we compared it with IPF, it had a phenomenal correlation. So basically proving that nothing but it's large. Large platelets are being misclassified as immature platelets. Now coming back to my 17-year-old boy. So when I looked at his smear, I saw these platelets. You must be thinking, are they platelets or lymphocytes? You look at the intense blue cytoplasm of the protoplasm of the platelet, not cytoplasm, protoplasm of the platelet. These platelets, I call them stress platelets, which basically means the platelets are going to be produced. Platelet production or platelet increase is imminent. So I call my anesthetist friend, ICU friend. I say that, your son has got stress platelets. So he said, what do you mean by stress platelet? I said, platelet, basically they indicate that the platelet count will come up any time from now. How soon? I said, maybe 6 hours. I don't know why I said 6 hours. So, okay, we'll check the platelet count after 6 hours. I said, why do you want to get himself poked? Anyway, next day morning, he'll have a platelet count. He's all right, fine. So we left it there. So we said that we'll collect the blood sample in the morning. So, must realize that the whole night I could not sleep. I did not sleep at all because I was terrified. So at 3 o'clock in the morning, I called the technician. I said, go and collect the blood. He said, no, we'll collect blood at 6 o'clock. I said, no, go and collect the blood right now. So he collected the blood and platelet count was 25,000. Now, coming back to this patient, 42-year-old male who had acute myocardial infarction, waiting for coronary angiogram. He's given a loading dose of aspirin and clopidogrel. And the cardiologist tells, can you identify whether this patient is responding to these antiplatelet agents? So we have few tests like aggregometry. Then we have got a VASP assay, which is done by flow cytometry. All of these assays showed that this patient is not responding to clopidogrel as well as aspirin. We have a PFA analyzer. So after all these tests, we tell that platelets are unresponsive to both. So he calls me and said, what do we do next? I said, sir, I am not a cardiologist. I'm a clinician, but I work in the lab. Now, if you tell me what to do, because you have been participating in all the antiplatelet drug therapy and trials, you should be making the decision. So he said, no, you have been telling us a lot of important information. You have to tell us. So, generally my teacher used to say that if you're in difficulty, you do one thing. Look at the peripheral scale. And peripheral scale give me the answer. What is the answer? They were large platelets, not large platelets. They were giant platelets. So you must realize that giant platelets contain more RNA than normal platelets. Each small regular platelet contains 9,000 transcripts of RNA. Some of them are functional. Some of them are, producing proteins. So you must realize that when you give aspirin to these patients, these aspirin have a short life. But once they are inside the platelet, their half-life is shorter, 1 minute. Because these aspirin will go and block a COX inhibitor. They are COX inhibitors, they'll block in a COX. But once they block a COX, the RNA in the large platelet will produce new COX. When you look for platelet function, the new COX is doing good function. The platelet will block the P2Y12 receptor. The RNA will produce new P2Y12 receptor. And the advantage of a cell counter is that I can identify these large platelets just looking at the histogram. So the opinion that was given is that instead of increasing the dose of aspirin, which he wanted, I said give aspirin twice a day instead of higher dose once a day. And after giving it twice a day, when he repeated the assays, it showed good response to aspirin as well as clopidogrel. So please remember, morphology is useful, but platelet histogram was more useful because platelet histogram reflected the presence of large platelets. This is an incident that happened, I think 5 years back. We have done a study with that. A pediatric hematologist, infectious disease person told that there's a patient with him with high fever who is 1 year, 2 months old. Your registrar has reported blast. Can you look at it and tell me? So, yes, there were reactive lymphocytes. There was an infection. If you look at the neutrophil and the lymphocyte, because I'm talking about not 5-part, I don't want to tell about it, but neutrophils and lymphocytes look very reactive. And there are even flags also of blasts and all those things. But what attracted my attention was the platelet count was 10 lakhs, 9,39,000, with a lot of reactive lymphocyte and reactive neutrophils. That is it, reactive lymphocyte, reactive. But look at the platelet histogram, it was normal. The distribution of platelets were normal. There was no platelet anisocytosis that you see in myeloproliferative disorder, where platelet count can be still lesser than 9 lakhs. This was only 9 lakhs. And I have been told by my professor that when you have a high platelet count in a patient who has got fever, just find out from the pediatrician whether the patient has got a bad cough with a whoop, because the lungs will produce more platelets from the proplatelet, and therefore the platelet count will go up. And therefore I asked the pediatrician, does the child have a bad cough like a whoop? And he said, yes. I said, this has got a diagnosis of pertussis. He didn't believe it, but he sent the PCR and came back as pertussis. Okay. Last 2 cases, a 24-year-old female, bleeding gums, mildly icteric thrombocytopenia, blood film. There is no platelets, but there is something else. There are fragmented red cell. Very easy diagnosis. Raise creatinine, LDH, and markedly elevated bilirubin makes your dive easy, and you can give a diagnosis of thrombotic thrombocytopenic purpura. But of course, ADAMTS13 deficiency, where assays are not easily available, and identify an autoantibody to ADAMTS13. Mortality is usually more than 80%, but if you start plasma exchange, you can bring it down to less than 20%. Now, you must realize that this PD could not afford plasma exchange. Developed generalized seizures, can reveal no IC bleed. That's because there is CNS symptoms in patients with TTP. Was transfused cryo-poor plasma. The peripheral blood smear improved. The patient improved, recovered after 7 days, was discharged. But she came back, relapsed in 3 weeks, and was advised plasma exchange. But you must realize that not ADAMTS13, but the fragmented red cell was the best predictor of recovery as well as relapse, compared to platelet count, LDH, bilirubin, and creatinine, which is known in TTP. And you must realize that these are reflected in the histogram. Now, last case, which actually happened in real life to me, I was a hematology registrar in Australia. Resident from accidents and emergency orders an urgent examination of blood film because a baby in the accidents and emergency pediatric is very irritable. So we are quite happy when we get the call at abnormal hours because they pay me $400 for minimum of 4 hours. But this will take me only 10 to 20 minutes. So I looked at the blood film and it was very easy diagnosis. There were blister cells, an irritable child, G6PD deficiency. So I was going to type white cell, blister cells, suggestive of G6PD deficiency. So I put the report. He called in the between. I said, this is G6PD. Then he said, hold on. So I was thinking, okay, fine. Not 20 minutes. Maybe I'll wait for half an hour. He says that this is a female baby. So now you're in difficulty because we know that G6PD is an X-linked recessive disorder and female. So then you beat around the bush and tell that, oh, this, G6PD, autosomal recessive PD have been described. But he said, why does this? So in the meantime, I changed my diagnosis from G6PD to acute oxidant hemolysis. Then he asked me, what do you mean by acute oxidant hemolysis? The child has got some oxidant stress because of something given to the child. So he asked what? So, when you read the chapter on G6PD deficiency, what is first in the list? Fava beans. So I said, for example, fava beans. This child is not going to have any beans, any type of beans, leave alone a morsel of rice. So, he starts laughing. So I also realized that I made a fool of myself. But this guy was persistent, and he said that the second child of the parents and was wearing the clothes of the first child, which was kept in a box full of naphthalene balls. And that, I said, can cause acute oxidant hemolysis. It was, such experiences are very good, but sometimes it comes in handy. So there was a pediatrician who's now a very senior pediatrician who was doing MD pediatrics. Now he subsequently became a senior pediatrician in Tejpur. When he came to do MD pediatrics and he was posted in neonatology, he called me and said, Sukesh, can you have a look at the blood film? The child is very irritable. So I tell him that this is looks like G6PD deficiency. There are blister cells and white cell. Then he says it's a female child. Then I tell him, go and ask the mother who is the second child and wearing the clothes of the first child. So then I put the phone down. 10 minutes later, he came back and said, how did you know that? So I said, a good morphologist can look at the peripheral smear and tell what the child is wearing. But you can see fragmented red cells even in the red cell histogram. So please do not ignore the histogram, especially for platelet counts. Thank you very much.
Sure. We have one question. Somebody is asking the difference between 3-part and 5-part in Coulter.
So thing is, 5-part, of course, is based on analyzing the white cell in the near native state in the Coulter, because they eliminate the red cells and make sure that the white cells are in the near native state with a good mixture of hypotonic and hypertonic solution. And then they use impedance for size. They use conductivity for difference between nucleus and cytoplasm, and also use scatter to identify granulocytes and agranulocytes. So that's how they use an algorithm to separate the 5. That's why it's called a 5-part, because it identifies all the 5 different. But you must realize that it's a single platform. It doesn't require different platform. In a single platform, in a XYZ cube, it can identify all the cells.
Dr. Manmohan Shakya is specifying the slide explaining histogram.
WBC histogram? Yes. So you can realize that in a WBC histogram in a 3-part, the white cells have lysed. So now only the non-conductive particles are the nucleus of the white cells. Now the nucleus of the neutrophil, which is 5-lobe, is largest particle in that whole thing, compared to a small nucleus of a lymphocyte and a small reniform nucleus of the monocyte. So the 5 lobes are the largest. That's why closer to the larger part. Some cell counters will be 300 femtoliters, some will be 400 femtoliters. The 5 lobes will come closer to the last part of the histogram. The 4 femtoliters will be before that. 4 lobes will be before that. The 3 lobes before that, and the 2 lobes closer to the nucleus. So the white cell histogram is purely counting the nucleus inside the cell and not the cell at all. So please understand that monocytes are not the largest particle in the 3-part cell counter. It's mostly the neutrophil. And of course, mostly normal human beings have 50 to 70% neutrophils and 20 to 40% lymphocytes. So they'll have a normal pattern. Only if you have some activity in the middle, you need to look at the smear. Otherwise, you don't have to look at this. Until unless you want to document megaloblastic anemia, where the white cells will fall beyond the histogram.
Another question: how is hemoglobin measured in modern cell Coulters?
So now you have non-SINEMET hemoglobin methods. Many of those who were using SINEMET hemoglobin have shifted to the non-SINEMET hemoglobin. They have different formulas. Some of the cell counters are using oxyhemoglobin method, which is oxyhemoglobin is actually closer to the gold standard. Because the gold standard we always think is SINEMET hemoglobin, but there's a golder standard than SINEMET hemoglobin, which is the oxyhemoglobin method. But nobody is using SINEMET.
One person is asking, Sir, in some 5 parts, arbitrary line of 100 and in yours 10, what to take cutoff for larger percentage in graph? I'm not sure I understood.
Some 5 parts, arbitrary line of 100. Okay, this is basically for the blast flag. In yours, 10. I can understand 100 or 10. It's not very clear. If you can explain that a little bit. Yeah.
Okay. In the meantime, we'll take another question. Sir, when to transfuse platelets in DHF?
Normally we, in hematology practice, when you have patients who have been given chemo, who are not likely to produce platelets, whenever the platelet count is less than 20,000 and febrile, we transfuse platelets. But in dengue hemorrhagic fever, they have large young platelets. So you can wait till 10,000. But if you have decided to transfuse platelet because you are evidencing some bleeding, you should make sure that you transfuse the platelets along with some FFP, because what happens is when you transfuse platelets alone, these platelets are going to be recruited into the microthrombi that is being formed by the platelets, and it can enhance end organ damage. So please do not transfuse platelets. In fact, in Malaysia, you cannot transfuse platelets to dengue hemorrhagic fever. You cannot transfuse platelets.
Same person, platelets in Celldyne. I'm not sure the question.
Yeah, so I think Celldyne Ruby is still probably impedance, not, I think the L-NIT is mostly optical, but Celldyne Ruby I think is still impedance, but impedance is very good. Impedance can count particles even up to 1 nanometers. So impedance is very good. So look at the histogram. Whenever you have thrombocytopenia, don't report platelet count without looking at the histogram.
They don't have any more questions, sir. I think that's all, sir. No more questions.
Fine.
Thank you very much.
Fine. Well.